Chapter 19 of ICD-10-CM is for injury, poisoning, and certain other consequences of external causes. This presentation will cover the official ICD-10 guidelines specific to this chapter. There will also be clinical scenarios to practice coding what you just learned, followed by a small quiz at the end of the presentation. For each coding example, you will need to pause the webinar and use your ICD-10-CM coding manual to code the scenario. Once you resume the webinar, we will go over the correct codes, the rationale behind them, as well as how to locate them in the ICD-10 manual. Keep in mind that there may be more than one way to find a code. We are aware that there is a great deal of information contained in this presentation. Therefore, at any time during the webinar, please feel free to pause and replay as needed. It is important that you have already completed the Introduction to ICD-10-CM webinar, as you will use the conventions and general guidelines discussed in this introduction to complete the coding scenarios. As you can see on this slide, the codes for this chapter start with the letters S and T, and you can see that they follow the order of the body parts from top to bottom, starting at injuries of the head, then moving to the necks, then thorax, then abdomen, etc. If you remember from ICD-9, these codes all started with the numbers 8 and 9. In ICD-9, these codes were grouped by type of injury as opposed to anatomical section. Therefore, in ICD-10, all head injuries are grouped together, including superficial injuries and fractures, whereas in ICD-9, all superficial injuries were grouped together, and then all fractures were also grouped together, etc. This slide contains the rest of the sections of Chapter 19. These are all T codes focusing on burns and corrosions, and then poisonings and adverse effects. As you saw in the two previous slides, the S codes are for injuries related to specific body regions, such as head wounds, hip injuries, etc. The T codes are for injuries to unspecified body regions, and then poisonings and adverse effects of drugs and adverse effects of things like breakdown of catheters or insulin pump leakage. Virtually all codes in this chapter require a seventh character, and this seventh character will depict the current episode of care: initial encounter, subsequent encounter, and sequela. For all codes with the exception of fractures, the seventh characters will be A for initial encounter, D for subsequent encounter, and S for sequela. When you're coding injuries, it is important to remember that the more serious injury is sequenced first, and that superficial injuries at the same site as a more severe injury are not coded. For example, if a patient had an open fracture of the left elbow and contusions of the left elbow were also documented, you would only code for the open fracture. However, separate codes for injuries at different anatomic sites should all be coded. The 3-digit code T07, unspecified multiple injuries, should hardly ever be used, as it is extremely nonspecific. This slide depicts all the seventh character options for traumatic fractures of all body parts with the exception of the limbs. You can see that we still have our 3 episodes of care: initial, subsequent, and sequela, but for initial encounters, which are seventh characters A and B, we need to indicate if the fracture was open or closed, meaning a fracture that did or did not break through the skin. For subsequent encounters, seventh characters D, G, K, and P represent a fracture with either routine healing, delayed healing, non-union, or malunion. And finally, S will always be for sequela. This slide depicts all the seventh character options for traumatic fractures of the arm or leg. You can see that the 3 episodes of care are still represented, as well as open and closed fractures, and the same healing types for subsequent encounters are also represented. But now, for open fractures, the Gustilo fracture classification is depicted, which you can see for seventh characters B, C, E, F, H, J, M, N, Q, and R. We'll look at the Castillo fracture classification on the next slide. The 5 stages of the Castillo fracture classification range from least to most severe. A type 1 is an open fracture with a wound of less than 1 centimeter with minimal soft tissue injury. Type 2 is a wound greater than 1 centimeter with moderate soft tissue injury. Type 3 fractures involve extensive damage to the soft tissues, including muscle, skin, and neurovascular structures. Type 3 fractures are often accompanied by high-velocity injuries, such as gunshot wounds or severe crushing injuries from car crashes or war and tornado victims. Subtype 3A is an open fracture with extensive soft tissue damage, but the periosteum membrane, which covers the outer surface of all bones, is intact. Subtype 3B is an open fracture with periosteum stripping and extensive soft tissue loss. Subtype 3C is for open fractures with major arterial injury requiring repair for limb salvage. The 7th character S for sequela is used for both traumatic fractures and all other types of injuries in this chapter, including burns and poisonings. The S is applied to the initial injury code to indicate that a condition is a late effect of the initial injury. Therefore, documentation should include the history of the initial injury and the late effect or effects the patient is now experiencing. In this chapter, 2 codes are needed to depict a sequela or late effect. Your first code is for the late effect itself, such as left ankle pain, followed by the code for a left ankle fracture, with a 7th character of S indicating that the left ankle pain is a late effect of a healed fracture. One of the reasons why there are so many more codes in ICD-10 than ICD-9 is due to traumatic fracture coding. Documentation for ICD-10 must include the specific anatomic site, such as medial condyle of femur, laterality, which should always be documented for this chapter. For example, it was the medial condyle of the right femur. The fracture type also needs to be documented, such as segmental, transverse, oblique, etc. You also need to indicate displaced versus non-displaced, open versus closed, and the current episode of care, which is initial, subsequent with routine healing, delayed healing, non-union or malunion, and then sequela. This slide is just a snapshot of some of the types of traumatic fractures that can be captured in ICD-10. You can see how specific documentation needs to be. Remember, even if the fracture is completely healed, but the patient is experiencing a late effect of the healed fracture, documentation must still include the specific type of fracture causing that late effect / sequela. It's not just for the acute phase of the injury that you need to be this specific. This slide contains a few coding pointers for traumatic fractures. If documentation does not indicate that the fracture is open or closed, meaning with or without breakthrough of the skin, the default for coding purposes is closed fracture. If documentation does not indicate that the fracture is displaced, meaning the 2 pieces of bone become incorrectly aligned, or non-displaced, believe it or not, the default for coding purposes is displaced fracture. Therefore, if you see something that just doesn't look right or is missing specificity, you need to definitely query the provider. Let's do a traumatic fracture example. The assessment states non-displaced traumatic closed fracture of proximal phalanx of left thumb after patient fell this morning. Therapy, short arm splinting. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The answer is S62.515A for non-displaced fracture of proximal phalanx of left thumb, initial encounter for closed fracture. To locate this code, you would start at fracture, traumatic in the alphabetic index. Your other option for a fracture is a pathologic fracture, but we don't want that because a pathologic fracture is caused by disease and is not the result of an injury. In the traumatic fracture section, you would then go to thumb, then proximal phalanx, then non-displaced, which points to S62.51 with a checkbox next to it indicating that more digits are required. When we go to the tabular, subcategory S62.51 is for fracture of proximal phalanx of thumb. Therefore, we are at S62.515, non-displaced fracture of proximal phalanx of left thumb, but the book indicates that a 7th character is required. To determine the 7th character, turn back to category S62 and find the box of 7th character options. Since documentation states that the patient fell this morning and is now being splinted, and that this is a closed fracture, a 7th character of A for initial encounter for closed fracture is appropriate. I want to talk briefly about dislocations. If documentation states that there is dislocation or luxation, this indicates displacement of a bone from its joint. The term subluxation means that there is partial displacement of a bone from its joint. If documentation states that the same bone is both dislocated and fractured, this would be coded as a fracture because it is more severe. Moving on to burns and corrosions in ICD-10. The burn codes are used when the patient was burned by a heat source, such as fire or a hot stove. The burn codes are used to report thermal burns that come from a heat source. There are also separate codes for corrosions in ICD-10, which did not exist in ICD-9. Corrosions are defined as burns due to chemicals. The guidelines are the same for burns and corrosions. This means that current burns and corrosions are classified by depth, extent, and by agent. Depth is classified into 3 degrees from least to most severe. A 1st-degree burn or corrosion is characterized by redness, while the 2nd degree is characterized by blistering, and the 3rd degree is characterized by full thickness involvement, meaning the burn/corrosion extends to all layers of the skin. The extent of the burn or corrosion indicates the amount of body surface that is affected by the burn or corrosion. We know that if a burn is due to a chemical agent, it is coded as a corrosion in ICD-10, whereas a burn caused by a flame is coded as a burn. Also of note, burns and corrosions of the eye and internal organs, which are categories T26 through T28, are classified by site, not degree. Therefore, a burn of the eardrum has no option for 1st, 2nd, and 3rd degree burn, just whether it was the right or left eardrum. In terms of sequencing multiple burns and/or corrosions, you're going to sequence the highest degree burn first. Therefore, if documentation states that a 20-year-old male was admitted for 2nd degree burns of the neck and 3rd degree burns of the upper back, you would sequence the code for the upper back before the neck, as a 3rd degree burn is the most severe. Also, if documentation states that the patient has 2nd and 3rd degree burns of the right shoulder, you're only going to code for a 3rd degree burn of the right shoulder, as the guidelines state that burns of the same local site but of different degrees should be coded to the highest degree. ICD-10, like ICD-9, contains separate codes for the reporting of total body surface area affected by burns, as well as how much of that total surface area was 3rd degree burns. The total body surface area codes are supplementary codes meaning that they would be reported in addition to the burn codes indicating anatomic site and degree of burn. The only time when these codes would be used as the principal diagnosis is when the site of the burn is not specified, and this should never happen. The good news is the guidelines only require reporting of the total body surface area codes when third-degree burns cover 20% or more of the body. Otherwise, using these codes is optional. Also, similarly to ICD-9, the total body surface area codes are based on the rule of nines. Here is a diagram of the rule of nines. It's called the rule of nines because the different areas of the body are divided up into zones of 9% or 18%. For example, the entire right arm, meaning the front and the back, has a total body surface area of 9%. The same goes for the entire head, meaning the front and the back of the head. So if we have a patient with a third-degree burn of the entire back of the head, since it's not the back and the front, but just the back, it would be 4.5% total body surface area. Now I'd like to try a burn example. A fireman suffered a third-degree burn of the scalp with a 2.25 total body surface area and a third-degree burn of the right forearm involving 4.5% TBSA while battling a house fire. He was taken to the emergency department and treated. How would you code this? And please also code for the total body surface area. However, don't worry about coding for the external cause of the burns, as that is its own separate webinar and external cause coding can get a little tricky. Please pause the webinar to complete this example and then hit play to continue and learn the answer. The first code is T20.35XA, burn of third degree of scalp, any part, initial encounter. To locate this code, start at burn in the alphabetic index and then find scalp. Indented below scalp are the degrees of burn, and documentation indicates a third degree burn, which points to T20.35, with a checkbox indicating that more digits are required. When we turn to subcategory T20.35 in the tabular, we see that a seventh character is required, and our seventh character options for the current episode of care can be found underneath category T20. Since documentation states that the fireman was taken to the emergency department and treated, this would be actively treating the burns, so a seventh character of A for initial encounter is appropriate. However, our code is only 5 characters long, and our A must be in the seventh character position. Therefore, a dummy placeholder X is needed in the 6th character spot. The next code is T22.311A, burn of third degree of right forearm, initial encounter. As with the last code, start at burn in the alphabetic index, then look for forearm, and then right. Indented below right are the degrees of burn, and we need a third degree burn, which points to T22.311 with a checkbox indicating that more digits are required. When we turn to T22.311 in the tabular, we see that a seventh character is required, which would also be A for initial encounter. The last code is T31.0, burns involving less than 10% of body surface. Even though only 6.75% of the total body surface area was affected by the burns, and the guidelines state that coding for TBSA is only required when greater than 20% of the body is covered, I wanted you to practice coding this in ICD-10. To locate this code, start at burn in the alphabetic index, then look for extent with percentage of body surface area in parentheses. Since only 6.75% is affected, the range needed is less than 10%, which points to T31.0, which you would then confirm in the tabular. Remember that the TBSA codes are supplementary codes, meaning they should not be the first listed diagnosis code. In terms of sequencing for the scalp and forearm burns, since they are both third-degree burns, it doesn't really matter which code is sequenced first. Our next topic is adverse effects, poisonings, and underdosing and toxic effects. To code these conditions, you would start at the table of drugs and chemicals, which for the Optum 2015 ICD-10-CM Expert for Physicians starts on page 339. If you turn to the table, you'll see that substances are listed in alphabetical order with columns for accidental, intentional, assault, and undetermined poisonings, then adverse effects, and then underdosing. We're going to discuss what those terms mean in the next several slides. First, I want to define poisonings, which can happen in a few different ways. A non-prescribed drug is taken in combination with a correctly prescribed and properly administered drug. This is a poisoning if it results in any drug toxicity or other negative reaction in the patient. A poisoning also happens when a drug that was prescribed to the patient was administered incorrectly. For example, a patient with atrial fibrillation was prescribed Coumadin, but at the incorrect dosage, and this resulted in negative effects for the patient. Also, if the patient received an injection by a nurse at the incorrect dosage, that would also be considered a poisoning. If an overdose of a drug was intentionally taken or administered and resulted in drug toxicity, it would also be coded as a poisoning. Finally, when a reaction results from the interaction of a drug and alcohol, this would also be classified as a poisoning. A toxic effect is a poisoning due to a toxic substance that has no medicinal use, such as ingestion of antifreeze or rat poisoning. Now we're going to talk about another condition found in the table of drugs and chemicals, which is an adverse effect. An adverse effect is a reaction to a drug that is taken as prescribed and is properly administered. This means that it wasn't anyone's fault that the patient had a negative reaction to a medication. The provider prescribed the medication correctly and the patient took the correct dosage, but a side effect of the medication still occurred, such as a blood clot resulting from birth control pills. To code adverse effects, the nature of the adverse effect goes first, which in our example would be the blood clot, followed by the code from the table of drugs and chemicals indicating the substance that caused the adverse effect, which would be birth control pills in our example. The code for the drug should have a fifth or sixth character of 5, which indicates an adverse effect. The last type of condition listed in the table of drugs and chemicals is an underdosing. Underdosing means taking less of the medication than was prescribed or based on the manufacturer's instruction, which results in a negative effect to the patient. An example of this would be insulin pump failure, where a type 1 diabetic patient receives less insulin than their body needs and subsequently goes into diabetic shock. The code for the drug indicating that an underdose has occurred should have a fifth or sixth character of 6 to indicate underdosing. If the patient intentionally or unintentionally underdosed themselves, a code for noncompliance from subcategory Z91.12 or Z91.13 should be used. Failure in dosage during surgical or medical care, which is subcategories Y63.6 through Y63.9, must be used with an underdosing code to indicate intent if known, such as Y63.6, underdosing and non-administration of necessary drug, medicament, or biological substance. When coding poisonings, if the intent of poisoning is not documented, accidental, intentional self-harm, assault, and undetermined intent, the default is accidental intent. The code for undetermined intent should be used only when documentation specifically indicates that the intent could not be determined. This might be the case for a patient who presents to the ED with rat poisoning and they are in a coma. The physician may document that he or she was unable to determine if this was accidental, intentional self-harm, or assault. If you look through the table of drugs and chemicals, you'll notice that a lot of the codes have X placeholders in the 5th character spot. Remember that the X placeholder has 2 uses. One use is that it is added when a code that is less than 6 characters long requires a 7th character, and the second use is to allow for future expansion without disturbing the code structure. For example, if we were to look up accidental poisoning by penicillin, the code in the table of drugs and chemicals is T36.0x1. The X placeholder in the 5th character spot may be replaced by a 1, 2, 3, etc. in the future, as ICD-10 may get more specific as to the type of penicillin poisoning, such as oral versus IV use. Remember, the X must remain in the code and no other character should be used in its place. This slide is very important because it contains the sequencing rules for adverse effects and poisonings. For adverse effects, you're going to code the patient's condition first, such as nausea or coma, and then the code for the substance that caused the adverse effect, with a 5th or 6th character of 5 from the table of drugs and chemicals. Conversely, for poisonings, you're going to code the drug poisoning code first from the table of drugs and chemicals, followed by additional codes for all manifestations such as vomiting and loss of consciousness. Substance abuse and dependence should be also coded if documented. Now let's try an example. A patient took an overdose of penicillin this morning, which was prescribed correctly and taken incorrectly. This resulted in projectile vomiting. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The first code is T36.0x1a, poisoning by penicillin's accidental, unintentional initial encounter. The first thing we need to do when coding this example is determine if a poisoning or adverse effect has occurred. Since documentation states that the penicillin was prescribed correctly but taken incorrectly, this is a poisoning. If the patient had taken the correct dosage and still had projectile vomiting, then this would have been an adverse effect. With poisonings, the guidelines state that the poisoning code goes first, followed by the manifestations of the poisoning. To find the poisoning code, go to penicillin in the table of drugs and chemicals. Remember that when the intent of the poisoning is not documented, the default is accidental poisoning, which codes to T36.0x1. When we confirm this in the tabular, we see that a 7th character is required. There is a box above the subcategory with our 7th character options, and since the overdose happened this morning, a 7th character of A for initial encounter is appropriate. Now we need our manifestation code, which is R11.12 for projectile vomiting. To locate this code, go to vomiting in the alphabetic index, then find projectile, which points to R11.12, which you would then confirm in the tabular. If a pregnant patient is injured or experiences a poisoning or adverse effect, the first code must come from subcategory O9A.21 for injury, poisoning, and certain other consequences of external causes complicating pregnancy, childbirth, and the puerperium. A code from this category should be sequenced first. Codes from the obstetrics chapter, which is chapter 15, always take sequencing priority over all other chapters in ICD-10. After using a code from this chapter, you would then use the code or codes that identify the type of injury or poisoning adverse effect and manifestations. Now it's time for our quiz. Our first question is what additional code would be assigned to show a burn involving 60% of the body with 40% third degree? The second question is a fracture not documented as open or closed should be coded to blank. The third question is a fracture not documented as displaced or non-displaced should be coded to blank. The last question is a corrosion is a burn from a blank. You can pause the webinar to write down your answers and then hit play to find out if you were correct. The answer to the first question is T31.64 for burns involving 60 to 69% of body surface with 40 to 49% third degree burns. To locate this code, start at burn in the alphabetic index, then look for extent with percentage of body surface in parentheses. Since 60% is affected, the range needed is 60 to 69%, and then indented below we need the range for the percentage of third degree burns. Since 40% is third degree burns, the range of 40 to 49% is appropriate. This points to T31.64, which you would then confirm in the tabular. Remember that the TBSA codes are supplementary codes, meaning they should not be the first listed diagnosis code. The answer to the second question is a fracture not coded as open or closed should be coded to closed. The answer to the third question is a fracture not documented as displaced or non-displaced should be coded to displaced. Remember that this is the funky one where the more severe form is the default. The answer to the last question is a corrosion is a burn from a chemical. Remember, the United States will begin using ICD-10 on October 1st of 2015. After the October 1st compliance date, it will be very important to verify that claims are being received and to check remits for denials based on the ICD-10 conversion. This concludes Chapter 19 of ICD-10-CM, Injury, Poisoning, and Certain Other Consequences of External Causes. Please feel free to check out our webinars on all 21 chapters of ICD-10-CM. If you need further assistance with ICD-10 training for physicians and/or staff, please visit the VantagePoint website at www.vantagepointconsult.com or call us at 203-288-6860.